a big improvement for our style life, knowledge for surgery, and scientific production to have the guide and the leading spirit of Alessandro. I hope that this spirit should be also evident in this webinar. We will have also Dr. Duccio Boscherini from Switzerland. Duccio was one of our residents more than 20 years ago, and now he's a chief of neurosurgery in Lausanne. Giampiero Tamburrini is the chief of pediatric section at the Catholic University of Roma under the guidance of Alessandro Olivi. Francesco Doglietto was one of our young neurosurgeons working here, and now is a professor of neurosurgery in Brescia University. And Maurizio Fornari is one of the most appreciated spine neurosurgeon in the north of Italy. Dominique Thompson is my reference point for pediatric neurosurgery, for spine pediatric neurosurgery. Is a wonderful neurosurgeon, a wonderful researcher, a very big friend. So I invited Dominique to start this webinar with his presentation on pediatric spine, Tales of the Unexpected. Please, Dominique. Dominique Thompson.
Yes, okay. Do you see my screen now?
Not yet.
We should ask the people that are not, that are just listening, the people that are not speaking, just to mute their own audio so that we can listen without interference. So I'm gonna deactivate my audio, my microphone.
And can you see my screen now?
Not yet. Not yet.
Let me try again. Is that any better?
Yeah.
Can you see the screen now?
Yes. Yes.
Excellent. Okay, well, good morning and welcome everybody, and thank you so much, Massimiliano, for number one, the invitation, and for your very kind introduction. So obviously I'm aware that there's going to be adult and pediatric specialists online, and so I thought for my short presentation I would concentrate on spinal anomalies in children. And I remember Tony Hockley, the late Tony Hockley, once said to me, he said, you have to remember, Dominic, that pediatric neurosurgery is not just adult neurosurgery in small people. And I think the cases I've chosen have really been to try and demonstrate that in the spine there are certain pathologies that are specific to children, and even when they're pathologies that might also be seen in the adult population, either the natural history or the management might be quite specific to children. So here's the first case. This is a baby born to a British mother when she was living in China. She was the first child, uneventful pregnancy, and there was no family history of note. And at neonatal examination, the child was essentially normal, except for the presence of anal stenosis. And the general surgeons there carried out an examination of under anesthetic and performed anal dilatation for the anal stenosis. And then after that, the parents were taught to serially dilate the anus to try and improve the child's anal function. But at 2 weeks of age, the child presented with irritability. She had a low-grade pyrexia, 37.8, and asymmetric movements in the lower limbs that had not been present previously. And she had this MRI scan, which you can shows clear abnormalities. There's what appears to be a sacral mass down at the sacrococcygeal region, but also quite significant changes within the intraspinal compartment as well. And in fact, the local diagnosis had been one of neuroblastoma, which I must admit I wasn't initially in agreement on when I saw these images. And so the child was transferred to the United Kingdom. When she arrived to us 2 days later, she had a flaccid paralysis in the lower limbs. There was urinary dribbling. We did a repeat urgent MRI scan, and you can see here again that this is abnormality down in the sacral region, but quite extensive changes within the spinal cord, including a syrinx that was extending up to the cervicomedullary junction. And all of this was significantly enhancing. So this is a child now. She's got a presacral mass that appeared to be present at birth. There's clearly an abnormality in the sacrum, and we know from the initial examination that the child has an anorectal anomaly. And this combination would fit with the diagnosis of Currarino syndrome, but rarely in this situation complicated by some form of sepsis. So the decision was clearly in the presence of this emerging neurological function, we decided to take to theatre to try and drain the empyema and to establish the microbiological diagnosis. So here's what we found at surgery. The lumbar region has been explored. Obviously, this baby's now only a couple of weeks old, and so the laminotomy in a child you can open with scissors. And the aim, as I say, clearly, although the spinal abnormality was quite extensive, we did a fairly limited opening over 2 or 3 levels in the lumbar region. You can see how injected and inflamed and hemorrhagic the tissues are, presumably as a consequence of the infection. So when we came to open the dura, obviously one of the prime requirements here was to get a microbiological diagnosis. And so we took a swab of the CSF and fluid there and then continued to open the dura. And once the dura was opened, you'll see that the spinal cord itself was very injected, the vascularity was very prominent on the surface, and around the outside of the spinal cord, you can see obvious evidence of a purulent discharge, which obviously we sent for histological diagnosis. The issue was what to do about the syrinx, because actually the enhancement worried me. And so at the time of surgery, I decided to perform a small myelotomy. And you can see here that on opening, this wasn't just a simple syrinx at all, but quite extensive pyomyelia. There was pus extensively involving the spinal cord along pretty much its entire length up to the cervical region. So we drained that, irrigated extensively, and you can see the cavity left behind there from the drainage. The cultures grew Escherichia coli. She had intravenous antibiotic treatment for 2 months and ended up making a very good recovery. As you can see, the syrinx and enhancement disappeared. She subsequently went on to get resection of the presacral mass, which was a teratodermoid. 5 years post-operatively, she's walking independently, albeit with an orthotic support on her foot, but she has a persisting neuropathic bladder. And so this is a case of a spinal dysraphism where there is an association with a syndrome. And certainly there are a number of syndromes in childhood that can be associated with spinal dysraphism, including the urorectal septal malformations, cloacal exstrophy, and so forth. But Currarino is one that definitely has a specific gene. It's autosomal dominant. And interestingly, this is another one of my patients with the same problem. You can see a presacral mass here with a sacral anomaly. And just to show it's an autosomal dominant, this is her 36-year-old mother who's actually presented for a long time with constipation, but subsequently when we diagnosed the child, you can see had this abnormality also. The second case is moving up the spine now. This was a 9-year-old boy who presented with a sudden onset of neck pain. There was no preceding history of trauma. He had no additional neurological symptoms, and the pain had been going on for 4 weeks prior to presentation. Interestingly, on discussion, he'd had a similar episode 2 years previously, and that had been investigated in his home country where he'd undergone a scan. Unfortunately, we didn't have that scan, but apparently he'd been diagnosed with an intervertebral disc rupture, which had been managed conservatively. It was a cervical disc rupture. When he came to my department, as I say, his pain was actually starting to improve. He had a full range of cervical spine movement. There were no neurological findings and specifically no evidence of myelopathy. But interestingly, this was his MRI scan. And you can see here there's a clear abnormality centered at the C3-4 level. The pathology appears to be centered on the disc. The disc is clearly very abnormal and probably extremely calcified. And in fact, that was confirmed on CT scan, and you can see this really quite marked abnormality compromising the spinal canal. We performed flexion extension studies, and actually there was no evidence of instability at that level. But clearly we've now got a child whose symptoms seem to be improving. He's got no neurological deficit, but obviously a very worrying picture. And the question really was what to do. My feeling was that we should probably do an anterior corpectomy and probably remove this area and stabilize that segment. Interestingly, at the time this child was here, I was with my friend and colleague Dakling Pang, who many of you will know, and he said, "Oh, I remember writing up a case like this many years ago." And we looked up his old publication, and his this publication, which had been termed juvenile intervertebral disc calcification, that Dakling had looked at many years ago. This was back from the sort of 1990s, and had found that this was a pathology that was recognized in children, very rarely, if ever, seen in adults. It was actually a calcification of the nucleus pulposus rather than the annulus fibrosis. The cervical region was much more common than the thoracic and virtually never in the lumbar, so obviously very different compared to adults. But actually, importantly, he pointed out in this presentation that in many situations, the natural history was quite favorable. And so we decided to manage this child conservatively since he was doing well. He was put in a hard collar for 6 weeks, and we did a follow-up MRI scan at 2 months. And you can see 2 months after conservative treatment, the area has completely resolved and virtually got back to normal. You can see here the difference between the presenting scan and the follow-up scan. So an example of a condition, juvenile intervertebral disc calcification. So disc disease with a natural history very different to what one might anticipate in the adult population.
We had an interruption.
Yeah, we are unable to hear Dominic. Probably some internet issue at his end.
Are we able to notify him that we can no longer able to listen to him?
Yes, yes. Professor Visucci, can you please give him a call? Professor Visucci, yeah.
Hello? I'm trying to speak. Hello, Dominic? Yes, yeah, yes. Yeah, and in a couple of minutes, just in case you don't realize the previous connection, we can shift to the second presentation, and we will continue with you as soon as you will become ready. Okay, for you? Okay. Okay, don't worry about. Okay. Okay, don't worry about it. Take your time, and we can start with the second presentation. As soon as you are ready, you will continue, okay? Okay, thank you, thank you. Bye-bye, Dominic, bye. Okay, I think he says that he still have some problems, some connection problems, so we can shift to the second presenter.
Mhm.
And as far as I remember, Professor Alessandro Olivi,
Yes.
should be the second speaker.
Yes, he is the second speaker.
Yeah, Alessandro, can you hear me? Yeah.
Yes,
Please.
I can start now. I'm gonna share the screen with you. So hang in there for a second.
Yes.
And let me know if you visualize the screen.
Not yet.
Hold on just a second.
So for all the panelists, due to some internet issues, we are shifting to the next speaker of the day, Professor Alessandro Olivi. Professor Visoci has already introduced him, but just a reinforcement, he is Professor of Neurosurgery, Director of Institute of Neurosurgery, Director of the Neurosurgery Residency Program, Agostino Gemelli University Hospital in Rome, Italy. His topic for today is the acute treatment of cavernous angiomas of the brainstem with incoming hemorrhages.
Let's see if it works. Hold on a second.
Mm-hmm.
Can you see my screen now or not?
No.
Yes, you do. Your face, but not your presentation.
Okay, hold on a second. It should come right now. Can you see it now?
Yes.
Yes, you do.
Yes.
Okay, excellent.
Yes.
Very good. Well, thank you very much for the invitation. I will talk to you about a topic, just giving you an outlook of the topic on the brainstem cavernous hemorrhages, malformation with clustering hemorrhages. Of course, I want to start to talk a little bit about the difficult problems that we encounter with this lesion is in our practice. Just for a quick overview of what I'm talking about, where most of you already know, is the pathology of the cavernous malformation, which are, as you know, mulberry in appearance with engorged purplish cluster of vessels, bilateral thin walls. And, this has been described in the mid-19th centuries. And there's been several reports about the incidence of brainstems of the cavernous malformation, and you can see that could vary from, depending on the series, from 4 to 35% of all the cerebral cavernous malformation. To me, it's very, I'm very pleased always to mention work that comes from my former institution, the Johns Hopkins University. Walter Dendy, the pioneer of neurosurgery, did the first description of brainstem cavernous angiomas. And it's interesting how he was also the first one to really tackle one of these lesions. And his description is quite telling, with that during the dissection, the tumor was thought to be a venous aneurysm, because there seemed to be a single sac with several large venous outlets, and because it was so compressible. It's interesting that after his report and everything, for the next 50 years, the area of the brainstem and the possible surgical treatment of this has been almost like forgotten for quite a while, because of the general feeling that the brainstem was indeed unsafe to reach. Of course, the neuroimaging that we use to outline these lesions are CT and MRI, with very little help from the digital subtraction angiography, because we know that these are capillary lesions and therefore not visible to, on the digital subtractions angiography. The association with the developmental venous anomaly certainly described. It's important to outline in a certain condition. These are all things just to give you the introduction of what my 4 cases that I want to present are going to be. There's been a lot of talk about whether these cavernous malformations in the brainstem have a higher propensity to bleed than the one in the supratentorial compartment, and this has been certainly the objective of a number of studies, and indeed some studies would hint that, of course, the symptomatic ones are associated with hemorrhages or focal neurological deficit, but that also skewed a little bit the evaluation of what is the true natural history of these malformations in the brainstem. So certainly these studies would certainly suggest that that a hemorrhage and the focal neurological deficits are indeed 2 things that characterized in a high incidence these cavernous sinus, these cavernomas of the brainstem. So even this study would certainly help in understanding the natural history and the surgical outcomes. A nice review indicated, and this is what of course, the challenge is that all these studies are retrospective in nature. This is a nice review by Robert Stark from the University of Virginia a few years ago, where indeed the reports have to be taken with a grain of salt, just because of selection bias, inconsistency, variable definition of hemorrhage and rehemorrhage, and always the small studies and sample sizes of the reports of these treatments. So we don't know in reality a number of aspects of the true natural histories of this hemorrhage. But let me just introduce to essentially 2 cases that I would say 4 cases that had a reasonable and a satisfactory outcome, 2 cases not treated with surgery, and 2 cases treated with surgery. So we all know that when we have an hemorrhage in this area, whether this is in the brainstem or even supratentorial, the neurological deficits quite often improve spontaneously. And these 2 cases essentially showed you a very benign course of this lesion. Case number 1, this was admitted in September of 2019 with acute onset of headache, dizziness, dysarthria, and dysphagia. This clinical improvement is probably due to the resorption of blood products. That's what we think. But from the emergency department to a local hospital, he was transferred to our institution. And this is the CT scan. They show the recent hemorrhage in the area. Of course, this is the MRI, which is the best way to assess this pathology. And you can see the hemorrhage and the lesion quite occupying a large part of the pons. In this case, there was no hydrocephalus, but there was evidence of a cavernomatosis, in other words, other location supratentorially of this lesion. We admitted the hospital, and during the hospitalization, he had a fast improvement of the symptoms. So this is essentially a very important decision making at this point, whether to observe these patients or whether to do something more invasive. In this case, the conservative management paid off significantly. He did not have a cluster hemorrhages. He was treated with steroids, and essentially 5 days after the admission, he started to have a normal swallowing test, and he made a significant improvement, which correlates with also the improvement in the images. You can see here the reabsorption of the blood, of the bleeding in the pons, and an MRI that correlates very well with the significant positive clinical picture. Here it is, just to see the sequence of MRIs that showed both the improvement on the images that correlates perfectly with the improvement of the clinical course of this patient. In the case number 2, again, another case that was not treated with surgery, acute onset of headache, mild left hemiparesis and numbness, diplopia, and right 7 cranial nerve palsy. In this case too, this one was higher in location toward the midbrain, as you can see, more on the right side. It was certainly asymmetric, and the patient had conservative treatment with fast resolution of the symptoms, and 2 months follow-up. The neurological recovery was very good, except for a mild right facial deficit. So you see how pronounced can be the spontaneous improvement. That's what we have to keep in mind in order really to tailor our treatment to our patients. We need to keep in mind that these patients quite often can make dramatic improvement in their clinical condition. 4 months follow-up, progressive clinical recovery, and 10 months complete neurological and functional recovery with complete reabsorption. You can see the huge difference in the MRI after 10 months and no recurrent hemorrhages. So the case is different when we have a problem of clustering of hemorrhage or incoming hemorrhages, and this is the focus of the second 2 cases that I'm going to present. The incidence of hemorrhage is unpredictable. There are periods of quiescence and then clusters of hemorrhage. For some patients, there is a period of instability followed by a decreased risk over time. And the hemorrhage clustering, the incoming hemorrhage, can be a common phenomenon and occurs more often in the first 2 years after the hemorrhages. So there is a significant decision-making process when we see this lesion in this particular sensitive locations. Clinical history, patient features, and lesion features all certainly are contributing to our decision-making process, or if and when offered to the patient a surgical intervention. Of course, we have to understand also the limitations, and here Mike Lawton certainly, who really gave some of the best contribution also in this kind of vascular pathology, outlines that many neurological deficits caused by hemorrhage ultimately resolve over time, and we demonstrated that. Additional hemorrhages create a new stepwise deterioration in baseline neurological status. When patients undergo surgery, it's very important to know that the procedure can often create symptoms that were similar, that can mimic exactly the symptoms of the previous hemorrhagic events. And surgery often, again, mimics an additional bleeding event with the hope that no further event will occur. That's the rationale for some of the surgical treatment. So this is just a scheme to outline what the indication, what the surgical indication. A symptomatic patient with an incidental finding, of course, at this point, we don't think that there is a surgical indication. First hemorrhage with stable neurological deficit. Well, this is starting to get into the, I would say, between the green and red area, the gray area, but certainly, as I demonstrated, it's also quite impressive, the improvement that you have even with the conservative treatment. recent hemorrhage with progressive neurological deficit, and finally, cluster hemorrhages with progressive neurological deficits. And that is exactly what I'm going to talk with the last two cases. Very important to get to the neuroanatomical correlation when you decide to have the surgical treatment. Here, of course, Bob Spetzler has showed different, described different approach according to the location of the malformation and the hemorrhage, from the cervical medullary junction to the midbrain thalamus junction. So different skull-based surgical principles according to the location of the hemorrhage, and also the so-called two-point method that has been proposed again by Spetzler. When you can, you have to try when you can to go to the first point as the center of the brainstem lesion, the second point, the surface of the lesion, as the best path to be effective in the resection. And the goal of surgery is certainly the complete removal, minimize damages, and to preserve associated venous anomalies. So, safe surgery. Let me talk to you a little bit about the two cases that we have, so we can discuss exactly what we wanted to about this recovery that these patients made. Patient, 41-year-old lady with acute severe headaches. After 1 week, recurrent headaches associated to progressive onset of right hemiparesis, significant, and left 6 and 7 nerve palsy. Admission at the emergency department, and once again we admitted, and this is almost similar in terms of the picture of the case that I presented before. But what is different in this is certainly that she had significant progression of the symptoms with a documentation of incoming and clustering hemorrhage in the subsequent MRIs, and she needed to be intubated. In this case, we took we made a decision to take her to surgery in order to certainly decompress the hemorrhage and remove the lesion. And in this case, we did a kind of a retrosigmoid lateral approach, provided with neurophysiological monitoring and NAP. We used the park bench position with the left retrosigmoid craniotomy. You can see the exposure of the 8th nerve area over here with the flocculus, and we identified the discoloration. Now I'm going to show you if I can, and let me know if you'll be able to see, but that's my approach, where we first see the area of the 8th nerve, and essentially we decided to enter the brainstem in the area between the lower cranial nerves, here visualized, and the 8th nerve. Now you're going to see the exposure of the brainstem, and then the decision. There is a slight discoloration, and the decision to enter. This is the confirmation with the neuronavigational system, and then here we decided to make an incision on the lateral aspect of the brainstem. Note how I used one of these knife that I had to extend in order to reach the area of the brainstem. And here I see the blood, the liquid blood clot coming out first, the opening of the lateral side of the brainstem, and here is the exposure, and in a piecemeal fashion, the removal through this approach, and here is the malformation, and in part the clot being removed in a piecemeal fashion with the constant neurophysiological monitoring. This is the probing with a nerve hook. You can see here that we identified another part of the malformation and the removal of that part through a microsurgical approach. This is just an approach where we thought that we were giving the patient the ability to reduce the chance of these incoming hemorrhages, and at the same time get the benefit of the removal of the clot. The post-operative course was fast recovery of the lower cranial nerve deficit with the progressive improvement of the right hemiparesis. The patient was sent, the hemiparesis improved from 2 to 5 to 4/5. She was transferred to the rehab program. I saw her recently. She's walking with the assistance of the walker, but quite independent in postural passage, and she's quite happy with the result of this of the course. The second one was instead a case that I did a few months after I took the helm of this institution. There is an 18-year-old male with subacute onset of right hemiparesis and diplopia, and this is really a significant improvement that the patient enjoyed after surgery. Progressive neurological deterioration, right arm plegia, and multiple palsy, and I think in this patient he had also significant deterioration of the level of consciousness. They had evidence of rebleeding, and that's for this reason, documenting the rebleeding, we decided, and given the clinical deterioration which was significant, to take him to surgery with a far lateral approach. This is a lower portion of the brainstem, and we took him to surgery. We don't have the clip of this operation, but certainly the operation was similar as far as the operative finding with the removal of the clot and the malformation. And this is the post-operative MRI with a progressive improvement. As a matter of fact, this kid went back home and went to college, and he had a significant functional recovery. And this is the most recent MRI that we took in the follow-up visit. So essentially, there have been a lot of work in predicting the outcomes, but what the bottom line is that the treatment in this for these lesions, more than anything else, should be tailored according to the presentation and the situation of the clinical situation of the patient and the images. So I want to conclude by saying that the management of brainstem cavernous malformations has evolved, of course, over the 20 years that we have followed, and once considered inoperable lesions, this lesion can be surgically curable, but it should not be one size fits all. One treatment applies in a blanket fashion, because it has to be, of course, tailored to each clinical situation. A general consensus for the optimal management for this formidable lesion is still lacking. Patient selection remains a critical determinant of the results and is derived from the identification of measurable preoperative factors that correlate with the operative morbidity and neurological outcome. Of course, something that I say all the time, no dogma exists. Our preoperative consultation must inform the patient of the possibility of new deficit. Surgical may mimics an additional bleeding event. Patients with best outcomes are those with follow-up of 10 years or longer with gradual improvement in new or prior deficit, and certainly multiple considerations, that's the take-home message, play a role in choosing the correct approach. Clinical presentation, lesion location, area to which the lesion comes closest to the surface, clinical functions of specific areas, pattern of distribution of associated hemorrhage, relationship with the adjacent DVA, and last but not least, the degree of comfort of the individual surgeon with a specific approach. Of course, complete resection is in many situations, not all of them, able to change the natural history of the disease. Thank you so much for the attention.
Thank you, Professor Olivi, for a nice illustrative, very nice illustrative presentation.
I want to thank you also the organizer. I want to thank Massimiliano, I want to thank Professor Signa, and certainly Dr. Chakrabarti from the Pink City that I visited, Jaipur is one of my favorite, if not my favorite city in India.
Thank you so much. Thank you so much, Professor.
Can you tell us why posterior fossa cavernoma bleed more, number one? And can you again enumerate to youngsters what are the common problems you face in surgery?
I heard your first question, and the first question is, do really brainstem lesions bleed more? As a matter of fact, this issue is unsettled. I think that is skewed also by the fact that these lesions come to our attention when they are clinical evident, and therefore we don't know exactly from the natural history standpoint, but it is a general consensus that we believe that they are more prone to bleeding. The reason of which I don't know if it is anatomical lesions or anatomical reasons, but I believe that it might be the relationship also with the degree of a developmental venous anomaly that can tilt the propensity toward the what I call the limited bleeding that sometimes we find in these lesions. And the second question, I didn't get.
Oh, do you use some hemostates for this bleeding? Local hemostates and all?
Hemostatic agents?
Yeah.
Well, I use, I apply the same technique that I apply in any of my surgery for the brainstem neoplastic lesions. So certainly the application of flow seal sometimes can help a little bit, but I really never had significant problem of controlling the hemorrhage in these cases, particularly because we operated in general at least a few days after the initial event, and being a capillary kind of lesion, when you remove the lesion, usually you're not left with a significant challenge from the hemostatic standpoint.
Thank you, Professor Olivi.
Max, you have to activate your microphone.
Okay. Can I ask you a question? According to the suggestion of Virendra Signa in the chat of this webinar, do you think that ultrasonography, intraoperative ultrasonography could be useful in this specific topic of cavernoma surgery, brainstem cavernoma surgery? What do you think, Alessandro? Do you think
ultrasound? You mean?
Yes.
I think that this might be helpful in cases where you are concerned about leaving a residual, because these are very echogenic lesions. We had accumulated more experience with the technique of the intraoperative ultrasound in the supratentorial and in some spinal lesion, where we were able to get, certainly in a situation like the one that I outlined, just the introduction of the probe in that area would be a little bit more difficult. But certainly we know that in some cases, supratentorial and spinal vascular lesions, the use of the ultrasound might give an additional help to particularly to verify that the echogenic area, the hemosiderin, the hemosiderin filled area is removed.
Thank you.
So for anteriorly placed cavernomas in the brainstem, Professor Olivi, do you prefer a subtemporal approach or Any other approach?
It depends again on the location within the brainstem. The upper lesions, when they are in the midbrain, they are anterior. I favor quite often the subtemporal or even the pteronial approach sometimes that can lead me to the lesions that are lateralized. For instance, the second case that I presented that was lateralized to the right, that if I had to choose a surgical approach, also because it was reaching the surface in the ventral portion, I would have very likely have chosen a pterional subtemporal approach. It was also on the right side, so non-dominant hemisphere. That would have been my preference. On the last case that I presented, it was quite ventral too, but with the far lateral approach that we were achieved, and this was a totally different case because it was on the lower portion of the brainstem. We were able actually with that far lateral to make an incision only a few millimeters from the midline, from the ventral midline of the brainstem. So as you can see, it depends where it reaches the surface, where it's located in terms of the height on the brainstem, whether it is lateralizing a little bit. So a lot of factors, but certainly in some cases, I do like to use the temporal approach, subtemporal, pterional, or modified lesion in that sense.
Thank you. So I suppose Dominic is back in line.
No. No. Oh, Dominic, yes.
Yeah, Dr. Dominic, are you able to hear us?
Unmute me.
Hear me?
Yeah. In the presenter view?
Can you see now?
Yes, yes, we can see now.
Okay, so I'll just, yes, so just obviously you'd seen the first two cases. I'll quickly just show them this last case. As I was explaining, this was a young lad with the autistic spectrum disorder. He's 4 years old, was admitted with a urinary tract infection to his local hospital. And during that admission, he had an episode of unconsciousness.
Dominic, we are having some problem with your microphone. Almost like
is that better?
Much better now, thank you.
Okay, my apologies. So yes, as a result of this episode of unexplained unconsciousness, the boy had a CT scan. And in retrospect, his mother said that his behavior had deteriorated in the previous year, associated with episodes of head banging. I'm not sure if you saw these pictures before, but this was his CT scan. The brain appearances were generally fairly normal. The ventricular configuration appeared normal, but it had been noticed that there was possibly some fullness at the level of the foramen magnum, and his cranial sutures, some of those appeared to be fused. When we saw him for examination, his neurology was basically fairly normal, though he did have a somewhat unsteady gait. He had no obvious syndromic features of craniosynostosis, and specifically, and I think importantly, there were no features of papilledema. As you can see here, his head shape is relatively normal, but as a result of those CT appearances at the foramen magnum, he had an MRI scan, which, as you can see, shows clear descent of the tonsils with an associated quite extensive syringomyelia. Now, in view of the combination of this with those behavioral changes and some stenosis of the, or some premature closure of the sutures, we decided to perform a period of intracranial pressure monitoring. And you'll see here that quite remarkably, despite sort of the absence of papilledema and otherwise no other significant features of raised ICP, you can see that his baseline pressures were consistently above 40 millimeters of mercury. So now we've got a child with raised intracranial pressure, a Chiari malformation, syringomyelia, and a relatively normal ventricular appearance. And the question really was, what were the surgical options? Because a shunt, there was really no particular indication for that. A foramen magnum decompression, our experience that doing that in the presence of raised intracranial pressure is not good in the longer term. So as part of our policy here, this child underwent a vault expansion with the craniofacial team. You can see here it's a spring-assisted cranial vault expansion. He had non-complicated recovery. He was discharged at 5 days. Now, 3 months post-operatively, he's still got the springs in, so we haven't done an MRI scan, but you can see here quite nicely that the syrinx cavity has clearly improved in the aftermath of that, and that's despite not having done anything at the level of the foramen magnum. And again, if you look here, here's the pre-operative MRI scan, and here's the 3-month post-operative CT. And again, I presented this just to show how pathologies may behave, or at least may have to be treated by a different paradigm in pediatric practice compared to adults. And last year, Massimo and I were involved in the special edition of Child's Nervous System. And I think there's increasing recognition that the Chiari-1 malformation, particularly in pediatric practice, a Chiari-1 is often the feature, the consequence of some other pathophysiological abnormality. And it's important to try and determine what is the cause before deciding on what is the specific treatment of the Chiari. And as I say, Massimo and I, Luca Massimi and I coordinated this in the special edition of Child's Nervous System last year, where a number of people have, I think, come to fairly similar conclusions. So thank you very much for your attention. I'm sorry for the interruption in the internet connection earlier on, but thank you indeed.
Thank you, Dr. Dominic. We had one question from Professor Sinha that when you were draining the empyema followed by a myelotomy, do you think intraoperative ultrasound would have been helpful at that point of time to differentiate a syrinx from a pus?
Yeah, I must admit, I think the value of intraoperative ultrasound there would be really purely one of localization rather than being able to distinguish between pus and fluid. I think one of the things that concerned me about that case was the extensive nature of the so-called syrinx and the fact that it was enhancing on the MRI scan. And it's very unusual for a syrinx to enhance in the absence of some underlying problem such as tumor or infection. And I think that, combined with the rapidity of the child's deterioration, is what made me think it was worth draining at the operation.
Great. Fine. Thank you, Dr. Dominic. Thank you.
My pleasure.
So moving on to the next speaker of the webinar today, may I request Professor Fornari Maurizio. He is the Division Director of Neurosurgery at Istituto Clinico Humanitas via Manzoni, Italy. And he has developed a lot of innovative techniques and instrumentations for spinal surgery. And he is one of the most recognized surgeons, not just in Italy, but also in Europe, especially for spine surgery. His topic for the day is anterior and posterior surgery for C2 anterior degenerative subluxation. Over to you, Professor Fornari.
So thank you very much for the invitation. I thank you, Professor Signo. I thank you very much, my close friend, Professor Visocchi. And trying to share my presentation. Beforehand, I want to compliment the previous speaker for the beautiful presentation and the fantastic case. The provocative title that Massimiliano gave me was about some miracle surgery that we performed. So I got it as a sort of possible way to look at something that I have done in a critical way, not in an enthusiastic way. If you are talking about anterior surgery now, it became very, very easy to approach by many different approaches any region of the anterior spine. Of course, you can do fairly everything, even by a standard submaxillary approach. I think that transmandibular approach is very nice, mostly when you're dealing with tumors. On the contrary, we do not like very much transoral approach, which is limited in the lateral exposure and has plenty of possible complication in repairing the mucosal layers. But as I learned from Professor Benzel, I visited him plenty of times, starting from 25 years ago when he was in New Mexico. What can you cut in between the paratracheal muscle and the sternocleidomastoid muscle? You can cut everything. I think that there are just very, very few anatomical approach where you have such freedom of cutting everything. There is no anatomical structure that you should avoid to cut. Of course, laryngeal nerve could be damaged, mostly on the right side, but this is not due to cutting of the nerve, but just to prolonged compression. So we do like very much anterior approach. We try to utilize this approach for any type of disease. Of course, if you're dealing with tumors, in most of the cases, you will also need posterior approach. Anterior approach will allow you, in any case, to rebuild something of the spine. On the contrary, the starting point of a posterior approach is demolishing the posterior tension band. It's easy to be performed, but as any time that you look at these images, you feel how many of these muscles you're destroying. Nevertheless, we are now going to talk about C2 subluxation. This disease, degenerative C2 subluxation, anterior subluxation, this pathological condition has learned us a lot of things, mostly the anatomy, the vascular anatomy of the posterior region of the C1, C2 spine. If you have to deal with the lateral mass of C2 and with the articular facet of C1, you have to learn the spinal root are passing. You have to know exactly where they will encounter the vertebral artery, and also you will try to manage also the intra-articular portion from C1 to C2, which is very important. I like to show this image. This is what the ancient Sonten construct, because in many cases, even now, many surgeons would forget that we are never performing just a fixation. We need to perform a fusion. And even if now it became very difficult to find the cable wire, because the best are now out of the market, I think that even the old iliac crest plus wires fusion still has a role. Just by this very, very simple technique, you could achieve good results. So don't really rely only on this course. A major step was done by Margaret, transarticular fixation. This is nice, and it's also in some way a complete fixation fusion procedure, because you passing through the articular facet, you are creating a disturb to the facet, and you're facilitating in some way the subsequent bony fusion. Of course, you can even augment it by the aid of bony pieces, but the procedure by itself, it's not just fusion, but something which is favoring the, not just fixation, but something which is favoring also fusion. It's okay, it's nice. Nevertheless, I don't want to spend too much time about that. I want just to make the most important criticism, which is the difficulty to achieve such an acute angle. Everybody who's dealing with the surgery knows that the kyphotic thoracic curve will make it very, very difficult to achieve. First of all, the entry point should be far below the where you have to work. And even by the end of navigation, it will be difficult to achieve finally such a simple contract. I would not rely completely on just facet fusion. I will also try to add some iliac crest bone fusion. This case is a case of dense fracture. Now, in any of these cases, we are using the arm and navigation. By the end of navigation, the proper trajectory can be achieved. Nevertheless, what happened in the surface is something that you would not like. So I would always suggest, in any case, to add some bony fusion. The major critical point is not really to damage the artery when you're putting your C2 screws in front of the bone. The major risk is to damage the artery. It's not depicted in the proper way here, underneath the lateral mass. The point where you can injure the vertebral artery is here, but by the aid of a navigation, it's very rare. Second procedure, the one by arms, which has been adopted now by most of the surgeons because it's quite easier, it's clean, and with some trick, it's even bloodless. So what we use now, when we have to position the C1 screw, which is the most bloody part of the procedure, we just add some fibrin glue, and you broke the veins. You let them bleed for a second. Then what you do afterwards is to close the veins with fibrin glue. We are performing about 400 cervical procedures in a year, 400 to 500 cervical or cervical, as the English guide says, cervical procedure in a year. So we got very accustomed to this surgery. You can treat any type of traumatic or degenerative disease in this region. And what you see here is intraoperative imaging, and this is also intraoperative imaging by your arm. The rescue procedure remains occipital cervical fixation, which I would try to avoid as far as possible. It became uncommon in rheumatoid arthritis, and it has plenty of complications. The rate of not fusion, it's estimated around 25 to 30%. So it's a procedure that I would like to avoid. No problem about positioning the screws in the lateral mass or in situ. Of course, as I mentioned before, very useful to have an O-arm. I know that also Massimiliano has got it now. To position a screw in C1 became fairly easy. You have to pay a lot of attention when you position a screw in C2 because sometimes you have the course of the vertebral artery coming up. So you have sometimes to keep your screw very short because maybe it's impossible to have a long screw due to this course of the vertebral artery. Brand new is the fact that you can also make a fusion. You can add to your navigation also images of angiography, CT angiography, or MRI studies. This can be very, very useful when you're treating tumors. I think that Massimiliano, who talked about after me about chordoma, can tell you the same. As a matter of fact, fusion, because in most of the cases, CT scan is not showing you the limits of the tumor. On the contrary, MRI and angio MRI will show you the real anatomy that you have to take care about. So first of all, I show you a very simple case where I did a sort of a miracle surgery. This case had an anterior subluxation of C2. This was degenerative. He had a myelopathic signal, which is not clear here, but he had a tetraparesis. We performed dynamic studies, and this did not correct in extension. Nevertheless, I made the decision to try to repair it by anterior approach. Finally, if you look here, how was anteriorly displayed, and you look here, just by a lot of fighting, finally we could achieve this fairly nice correction of the subluxation. And the control study, what you see here, it's a beautiful fusion. What we used was a completely titanium cage and a lot of coorientation of C3. And looking at it, you would say not so nice, but finally the clinical result was okay. Also, the anatomical result was okay. This is a sort of miracle, but due to the fact that we had to fight so much to achieve this good clinical anatomical result, but not so completely correct in its planning. What I want to show now is the second case, which came just after the previous one. And in this case, our attitude was completely different. Don't search for a miracle, search for a planning. So this case was quite similar, anterior degenerative subluxation. C2, C3, sort of Clipper fail syndrome here. It's not quite clear if these two, there is a long C2 or a fusion in between C2 and C3. No way to achieve any correction in extension or any significant movement in flexion. So what we did was not to try to solve everything by anterior approach. We went posteriorly. We made a release of the facet C2, C3. Look how near were these two facets due to the anterior diastasis of luxation of C2. And this was what we could achieve by the posterior approach after release of the facet, which was completely insufficient. Then we moved the patient, which was in prone position, in supine position, removing the rod. You see how it changed just by changing the positioning. It moved upward by itself and posteriorly by itself. This was the initial picture. Then we went anteriorly, we performed the somatectomy, and this was the final step of the anterior procedure. Then we went back again. Now you see how far are C2 from C3 screws due to the reduction and distraction that we achieved by the anterior approach. And then we compressed to recover the lordosis, the proper lordosis. So this was a first step. This was a second step, prone, supine, without rod. And this was anterior approach with distraction and reduction. This was the end of the procedure with the positioning of the posterior screws. So what we did was to go anteriorly, posteriorly, anteriorly, and then again posteriorly. And I think that this result, it's not a miracle result, it's a standard result, but in this time, I do believe that we do not have to search for a miracle, we have to search for proper approach and a planned and a carefully planned approach. Thank you very much. This is Professor Servadei, who is the president of the World Federation, who's saying hi to everybody. Thank you.
Thank you. Thank you, Professor. Professor Visochi has a question for you.
Yes, congratulations. Very, very impressive presentation. All of us knows your huge experience in general neurosurgery, but mainly in spine, cervical, craniovertebral junction. I congratulate. You spoke about different techniques. What do you think about transarticular Mager technique? Is it still a viable technique or quite completely overcome and completely disappeared after Goel arms rising up technique? Which is your personal experience? Do you still perform transarticular Mager technique?
No, for different reasons. First of all, if you're treating traumatic cases, the instability is such great that you are always to keep in some way stable C1 and C2. Meanwhile, you're drilling through the facet, which are hard rock, solid bone. Secondly, because it's impossible to perform any sort of correction, because you cannot distract, you cannot recover some lordosis. And third, because if you are not forced to work too much in the facet, I think that you will have less bleeding or less problem of controlling the bleeding. So And in also the third reason is how it is difficult to achieve such a proper trajectory. It's fairly impossible just to have the trajectory in a short cervical incision. You need to have an entry point which is in the dorsal region.
Thank you.
Okay, I want to ask, do you use 3D technique for CV junction? Because we use 3D technique for cranioplasty, for posterior fossa aneurysm surgery, for tumors, for ABMs. We are using 3D printing techniques. So do you use this for CV junction surgeries?
Do you use imaging technique?
No, 3D printing technique for models.
3D printing? No, not really. I think it's a good suggestion. I guess that in the future we will have first of all augmented reality, which is now coming, and which is the great advantage is that it's give you a fusion between MRI, CT scan, X-rays, and also 3D printing. So we did not use it. We have the device for doing it. I think it's a good suggestion. I wanted to couple it with the augmented reality that we're using now.
So we are using for last 5 years, and you will surprise that we are making these models, 3D printing models, at the cheapest rate in the world. It's very cheap. So we have a very good friend who makes all the models for us, a very cheap rate, and each model for CV junction cost $150. That's all.
Yes, company. Maybe we can adopt your solution. We will. Everybody will be in trouble now. So less expensive, the best.
Yeah.
Thank you. So now we are moving on to the fourth presentation. Professor Visochi Massimiliano. He needs no introduction. He is the director of Craniocervical Junction Neurosurgery Unit at the Catholic University Escuolo Policlinico Gemelli, Rome. He is the chairman of Neurorehabilitation and Reconstructive Committee of the World Federation of Neurosurgical Societies, secretary of the Craniovertebral Junction and Spine Society. Also, he is the board in World Federation of Cranial Nerve Disorders. Today, he shall be talking about a 6-level cervicothoracic spine circumferential demolition and reconstruction in chordoma. Professor Visochi, may I request you?
Yeah, thank you. Thank you very much for your beautiful introduction. I'm proud to be part of this team with Dr. Signa and to provide sharing our experience in a different field of neurosurgery. The spirit of this webinar is to highlight very challenging situation where we can choose between two opportunities: to do nothing or to try to do as much as possible with some risks. We will better understand this concept during this presentation. This is a clinical case which who underwent our attention and observation many years ago, and coming from other hospital. She was a 45 years old female with an history of chordoma, or spinal chordoma, which was diagnosed on April 2005. At the very beginning, it was a CAT scan, MRI examination, bone scintigraphy examination to highlight the diagnosis of C6 body chordoma. On March 2006, chordoma of C6 was recurring, and it was reoperated in 2006, 1 month later on. And interlaminar hook in the posterior instrumentation infusion technique was performed at C6, C7. On the same year, September, a C5, C6, C7 somatectomy with C4, T1 instrumentation was performed. And again, in the same year, on October, 1 month later on, a T1 somatectomy with distraction of the construct was performed, as well as a radiotherapy treatment 1 year later. This is the abstract, the very, very strict summary of this very complex clinical history. Let's start with the very first images. At March 2005, you see here on the left panel X-ray standard, and the center CAT scan, and a bone scintigraphy showing an hypercaptation and bone involvement at C6 due to a chordoma. As you can see in an axial reconstruction, bone chordoma is not only on the bone, but also around the soft tissue on the right side of the neck of this patient. If you can see at the bottom of the panel, you can appreciate a couple of bodies above and a couple of bodies below the C6 center of the tumor, completely involved. But nevertheless, the operation was at the very beginning a sort of a biopsy, and then a posterior interlaminar hook C6, C7, and then C5, C6, C7 somatectomy. So a very strange construct, asymmetrical, and very, in my personal opinion, unstable construct, and not overlapping the real extension of the tumor. The patient underwent our observation with a compromised motor and sensory picture with allodynia, dysaesthesia, hypofunction of lower and upper extremities, and this was the X-rays soon after the admission in our department. As we can see, the construct was unstable. The posterior instrumentation infusion was not covering the real extension of anterior somatectomy. And according to the CAT scan and the MRI examination, there was an impingement of the cord, justifying the clinical impairment. And you can see also in the sagittal reconstruction at the MRI further caudal extension of chordoma. As a matter of fact, we decided to perform a radical decompression of the recurrence, a removal of the anterior and posterior hardware, and a complete 360-degree reconstruction of the cervical thoracic spine. But before to proceed in that way, we felt the need to perform a 3D reconstruction of angio CT scan in order to evaluate the best chance to get in the thorax to reach T2, T3 by anterior approach. And we asked to the cardiac surgeon to help us by performing a partial sternotomy and allowing us to control the anterior aspect of the upper thoracic spine. the patient underwent a double-stage anterior and posterior approach. Between the first and second operation, 1 week lasted, and the diagnosis, histological diagnosis, confirmed the very first diagnosis of chordoma with all chemical, antigenic, and molecular analysis performed. Anterior approach was necessary as a first step, and after de novo, a removal of the very first hardware, the novo somatectomy was performed along with the grossly tumor debulking at T2, T3. And it was put in the surgical space appropriately sized lordotic titanium cage C4T4, along with an anterior plate C3, C4, and T4. Then the patient underwent allovest immobilization. The operation, first step operation, was 5 hours duration. This is the anterior construct. I remember that we asked from Germany for the anterior plate because it was at that time it was not available a so long anterior plate. Also, the mesh, lordotic mesh, was prepared according to the huge anterior decompression. More than a week later on, it was performed posterior approach consisting of T1 laminectomy and grossly tumor debulking. Under fluoroscopic control, it was performed posterior instrumentation and fusion with lateral musculus starting from C3, C form up to the pedicles of T3, T5. 6-hour duration. This is the final construct, 360-degree reconstruction. And at that time, we didn't use O-arm or intraoperative CAT scan. We use a simple fluoroscopic assistance, and the operation was clinically effective and was associated with a post-operative assistance with the allovest. Now I want to show you some steps of this very complex and difficult, in my hands, difficult operation. You see, this is the neuroradiological assessment just before surgery, and this is the 3D reconstruction of the aortic vessel. This is the opening on the left side up to the upper third of the sternum. The cardiothoracic surgeon offer us this exposition, and here we have the heart and the aortic vessel covered by the sponge. First step is just to identify, to clean, and to remove the anterior plate. And just beneath anterior plate, there is the somatic prosthetic, the expandable cylinder, full of scars and tumor. First of all, to isolate it. Second, to remove without damaging the spinal cord, of course. Here we can better complete removal both of the bone and of the remnants and the recurrency of the chordoma. Now you see here the mesh with this blue line inside here. This is the midline of the mesh, and it helps us to maintain the lordotic curve in the right orientation, otherwise could be unfair and not working according to our willing. We put the mesh in this huge surgical field, and soon after we put over the plate. This kind of plate is very different from the one we are used to implants in normal surgery. We have not a couple of holes, just a line, vertical line of holes for screws. As soon as we complete anterior instrumentation and fusion, we close the sternum, and this is the final results of the first step without posterior instrumentation. Then 12 days later on, second step in allotraction, the patient in prone position. We open the old scar, and we try to isolate the surgical field according to the need to both to remove the recurrency of the tumor. Here you see localization of recurrency according to the nature of the chordoma. Chordoma is not only impinging the dura, but also getting in the dura through a hole. And as soon as we remove the tumor, the CSF rise up, pop up, and so we have to try to close this CSF fistula with microsurgical technique. And soon after, I'm sorry, and soon after we put some glue inside. Then we continue to instrument by screwing the spine, both cervical and thoracic spine, and put contoured rods in the tulip of the screw. The rods are contoured in the operating theater according to the curvature of the cervicothoracic junction, and then ensured tightening the rods and the tulip. And this is the intraoperative X-ray control and the post-operative final control according to what we already show in the first part of presentation. But which was the post-operative course? Despite the difficulty, the challenging of the operation, the patient was doing well no more than 6 months. At 6 months, there was a huge recurrency of the tumor, and at 7 months follow-up, the patient died for respiratory insufficiency. Did we well? Could we change something? Anyway, let's go a little bit on the back and remember that extensive resection provides the best chance for chordoma, and the nature of the chordoma is important for predicting the follow-up of the patient. The loss of p53 function and telomerase expression means that the chordoma is very aggressive. Typical chordomas has proliferative activity higher than chondroid chondromas and chondrosarcomas. Despite the name, chondrosarcomas are more benign than chordomas. So in this condition, with this proliferation index, with expression of telomerases and loss of p53 function, we have the diagnosis of a very, very aggressive, quite incurable tumor. To our knowledge, it was the second case operated at that time, 2006, of 6-level, 360-degree cervicothoracic decompression reconstruction. We also published this experience, but right now we continue to ask if we did well. For 6 months or survival, we spend so much energize and ask the patient to afford a so complex, time-consuming operation. Probably could return back in the time, probably we had changed our philosophy, but we put into the discussion also the indication of this surgery. Thank you very much for your attention.
Thank you, Professor Visochi. Really interesting case presentation. And of course, it will always be a point of debate whether the prognostic, the malignant nature of the disease, should it change the treatment strategy? I have one question for you, Professor. In such kind of a 6-level decompression and reconstruction, suppose this would have been a more benign pathology. Do you think a bone, instead of a mesh, a bone graft would have been better had it been a more benign pathology?
In benign pathology, it could be a matter of discussion. For sure, bone is better than titanium. But in this special case, we had so huge reconstruction to perform that I think that we had to harvest a very generous bone dowel from the body. I don't know. It depends on personal experience. I know that in a Western country, it much more preferred the hardware instead of biological materials like autologous bone. We were used 20 years ago to perform harvesting from iliac crest 2 for cervical surgery, standard cervical surgery. With time, we changed our idea and we use expandable devices. This is another important topic to be discussed as well. Expandable is a quality typical of the hardware. Otherwise, biological tissue, bone harvesting product are expandable. So this could be a little difference. On the other hand, it is much more compatible with the human being. So adverse effects are less evident with biological material compared to titanium. We have also to add that when we harvest something from the body suffer, and we can face with complication related to bone harvesting. I remember that when I were to harvest from iliac crest, the patient was very happy for cervical surgery, but very painful and complaining for the pain and the aroma associated with the iliac harvesting. You know, it's a complex matter to be debated, but thank you for your question.
Thank you. Dr. Fornari, I suppose you have a question? Dr. Fornari?
Yes, everybody who's dealing with chordoma in any region of the spine has now a major problem. When you have to rebuild, it's very easy to rebuild by titanium, but now you know that everybody is forcing toward proton beam therapy. In this case, I think that the first target was to rebuild stability of the spine. So Professor Visocchi had no choice. But I think that my personal consideration is that we are really lacking technical instruments which are proper to perform both surgical removal and proton beam afterwards. So now we know that there are some trial going on, mostly on sacral chordoma, just the proton beam against surgery or compared to surgery. And we are participating to that. In my opinion, I think that we need some new technological advancement to create mostly proper solid screwing, which is compatible with proton beam therapy.
Yes, good question. Thank you very much, Maurizio, for your
and
comment.
compliments for the presentation.
Thank you very much. As a matter of fact, this patient underwent a conventional radiotherapy before the dislodgement, the hardware dislodgement. And the post-operative natural history was so fast to plan proton beam, if possible, after conventional radiotherapy. I think that your attention to the material of instrumentation is very correct, because as we all know, to perform proton beam radiation therapy, we should use carbon hardwares instead of titanium hardwares. And the availability of this material, at least in our hospital, is not so easy. I think that could be difficult everywhere, but some special place. For this motivation, according to the suggestion of the moderator, I think that bone should be preferable, because with bone it is possible to perform proton beam, and there is a major indication to reconstruct by autologous material in view of a complementary staged proton beam.
Yes.
Thank you.
At the same time, if I can add something, in England they have plenty of experience with proton beam, and what they tell you is that afterwards we have plenty of necrotic tissue around the tumor, so that surgery becomes fairly impossible, because even superficial cutaneous, subcutaneous tissue are completely devascularized. So, required, in my opinion.
Thank you. So may I welcome Dr. Tamburini Giampairo. He is the Permanent Associate Professor in Pediatric Neurosurgery at Institute of Neurosurgery at Catholic University Medical School in Rome, Italy. He is National Qualified Full Professor of Neurosurgery at the same university since February 2016, and Chair of Pediatric Neurosurgery Unit at Fondazione Policlinico Gemelli, IRCCS in Rome, Italy. He is the President-elect of European Society of Pediatric Neurosurgery, Advisor Membership Committee of ISPN, Associate Editor and Main Editor of the section Controversy in Pediatric Neurosurgery for the journal Child's Nervous System. He has been author and co-author in more than 190 publications. He has participated as faculty in more than 50 international pediatric neurosurgery courses, giving 140 plus lectures. He would be talking about congenital giant hemorrhagic lesion in neonate. Over to you, Professor Tamburini.
Thank you, Professor Signa, and thank you, Massimiliano, for involving me today in this webinar. Actually, we are going to change a little bit the topic of the morning. I compliment all the previous speakers for the extraordinary surgery I could see in the spine. As pediatric neurosurgeons, we are, on the other hand, dealing frequently with many other difficulties, and this kind of difficulties may come, as in this first case I'm presenting, already at the time of consultation of a mother waiting for a baby. So this is the first case. It is a baby at the time of this MRI at the 23rd week of gestational age for the mother, and she presented to us with this MRI that was performed after an ultrasound evidence at the 1 week before we saw this patient. So we see the fetus with the brain and this large lesion, which is actually we see on the right parietal region. This is axial view of the same fetal MRI, and going on a kind of middle between sagittal and axial view of the same lesion. You see that it's a huge compression of the brain by this lesion that has blood inside, mixed content inside. The mother went to a primary center where she was advised to think to abortion, that it's in Italy allowed up to the 25th weeks of gestation. And so after this primary consultation, she asked for a second opinion, and she came to me showing MRI involved, because the original diagnosis was of a brain tumor, malignant hemorrhagic brain tumor. But I told the mother that actually I could see the brain around the lesion, I could see a space between the lesion and the brain, so I was not sure that this tumor, this lesion was a primary brain tumor, and more than that, it was not sure it was a malignant brain tumor. So the baby, the mother decided to go on with gestation, and the baby was born at 35 weeks with an APGAR of 8 at 1 minute and 10 at 5 minutes. And this is the MRI at birth, few days after the second, third day of birth. Clinically, the child had a right occipital prominence with an anterior fentanyl which was full but non-tense, and he did not have any focal neurological deficit. So this is the MRI at birth, few days after birth. It is true it is a large lesion, it is true it is an hemorrhagic lesion with a lot of blood inside, but you see there is a clear separation between the lesion and the brain, which actually could be already seen, in my opinion, in the fetal MRI. So there is even maybe a sulcus here with some CSF around between the lesion and the brain. You see the large occipital, parieto-occipital prominence around. So what to do in this neonate? 3 kilos, really evident compression of the brain, but the baby is okay. In these cases, it's a little bit different. We can, in neonates, at least fate a little bit more on the compensation by the expansion of the sutures. So the cranium of the neonate has the possibility to compensate, at least at the beginning, to this large compression, but we are also sure we cannot wait too much because the brain compression is really evident. These are other sequences of the MRI after contrast. Again, you see large lesion, really significant compression of the brain with an important shift of the right parieto-occipital region under the falx on the contralateral side, but you see that it's confirmed that this lesion that is separated from the brain, so it's not primary a brain lesion. So what could be? With this large hemorrhage and this kind of MRI, we asked for an angiography to see how was the vascularization of the lesion. This is the angiography that was performed at 1 week of age of this baby. And you see that this lesion is vascularized prominently by the parietal branch of the right meningeal artery, with many kind of arterial feeders to this certainly could be a malignant lesions of the meninges. We cannot say no, it is an hemorrhagic lesion with a lot of feeders from meningeal arteries. In this baby, it's obviously one of the problems when we afford the surgery, as Dominic, which I hello Dominic, how are you? Not operate this neonate of 3 kilos as even an older child or an adult. So we asked the endovascular surgeon to do something for us, and he proposed to partially embolize the lesion with coils, and you see here on the right the first coil and the main feeder that was posted by the endovascular surgeon. And then we went to surgery. This is the situation at surgery at the time of skin flap as position of the bone. We have bone which is largely vascular tissue embedding the bone for all its extension around the lesion itself. So we went around all the bone that was involved by this largely vascularized lesion, and this is once we went on the inner part of the lesion with a big clot inside the main connective tissue, which appeared to be connective tissue composing the big bone lesion that we were facing to. And this is the dura exposed at the end of the removal of the lesion. So this is almost at the end of the first surgery. Obviously the neonate needed to be blood transfused, but the post-operative course was okay. So this is the bone at the time of the removal, and you see the bone inside with these radial aspects, which is an unusual kind of lesion, but it's a lesion of the bone. This is the aspect of the central part of the lesion, of the most prominent invasion of the lesion, which was in the central part. So what it was thought to be a malignant primary tumor actually turned to be a vascular lesion, and histologically, as you could see already, a bone capillary hemangioma, so a benign lesion. So this is the real miracle of the nature for a baby that was destined to abortion. And this is the immediate postoperative MRI with no neurological deficit of the baby. And we followed up the baby in months, and this is the 6 months MRI of the baby. You see how babies can do by themselves with a normal repositioning of the brain that was originally so much compressed and pushed on the other side. No real brain damage. The baby was already in normal neurological conditions and continued to be in normal neurological conditions. And then we have another problem as pediatric neurosurgeon. We have a large bone defect. This is another another pill of pediatric neurosurgery that I want to share with you. So at 1 year, the baby starts walking and goes to risk to add injury. So you have to take a solution. And this is a very active baby going around all the house. So in principle, we said to the parents to put an helmet to protect him, but then we need to find some solution. You see the CT scan in preparation for cranial reconstruction, which is really a big problem for pediatric neurosurgeons in the first year of life. We don't have materials that are useful for neonates because the skull is growing, so no material will stay inside without being pushed back or resorbed. So one of the things that we are considering, especially we were considering in the past, is bone splitting from the other side. But you see that the bone thickness is not that large. It's less than 5 millimeters. So bone splitting really is not considerable in this case. And you see these are simply the spirals that were residuating from the embolization that happened us for the surgery. So in these cases, what is now the practice of pediatric neurosurgeon is another kind of thing is what we call exchange cranioplasty. So do a bone flap exactly on the other side, parallel on the other side, which resembles the site of the defect. This is the site of the defect. The baby is in prone position. These are the two parietal areas. This good bone from the other side. You have to preserve really carefully all the periosteum, the galeal tissue, because it's very important for the reconstruction in the donor site. And you take a donor tissue, which is the parietal bone, and then what you do, you put it on the affected side, and this is the bone on the affected side that is going to grow and be integrated on the side. It's the only way you can use to have some possibilities for the bone to be integrated on the other side. And what to do on the affected side, we have experience also to do nothing. The important thing but mesh to protect the child, because again, as walking all around all the time and going with this head again against way, the the is sane at the beginning in this neonate. So I think when you, as in these very small children, you don't have the possibility to split the bone, the solution, the most promising solution is this kind of surgery, what we call exchange cranioplasty. So this is the conclusion of this first case. I asked Massimiliano if I have still time, but I think I have already used around 15 minutes. So Massimiliano, what do you say? Should I stop here or go with some other case? Or Professor Signa, what do you say? Should I stop?
No, you want to present other case?
Well, let's stay if you want. We can present.
No problem. No problem. I think.
Okay.
Sorry, Giampiero. Sorry, I had some problem with my microphone, but I heard you. You can go ahead if no one.
Well, we can stay on the same topic, and let's see this other case. Again, it's a fetal consultation for another guy with this kind of hemorrhagic lesion, not so large as the one that we saw in the previous fetus, but deep in the parietal temporal region, temporoparietal region, and in this case on the left side. At birth, this child that we just said that we have to see what happens when he will be born, but just at birth he had a respiratory distress with the right side hypotonia. So he underwent this MRI after he was intubated, showing again a very large hemorrhagic lesion of the brain. In the deeper part of the brain, this is the basal ganglia region, huge hemorrhagic lesion. It's a problem, really a problem for a pediatric neurosurgeon, what to do. The baby is really unstable, it's not doing really well. So these are other sequences of the MRI. We see large clotting lesion involving again mainly the deep part of the right hemisphere in this neonate. And these are other sequences of this MRI. So what would you suspect, Dominic, on this baby? Do you have any opinion? And what would you do? I think you can open the microphone.
Yeah.
Yeah, thanks, Giampiero. Yeah, I mean, as you say, the age is such a formidable challenge here. But I guess, I mean, clearly, I suspect, you know, the possibility of some congenital vascular abnormality, but also, you know, some form of primitive tumor, I think have to be considered here. And I wonder, I mean, I'd be wondering whether or not actually, at least in the first instance, trying to find some form of histological diagnosis, because as I say, you know, if this ended up being an atypical pterygoid or rhabdoid or some very malignant tumor, then clearly one would have to be a lot more pessimistic about the outcome. So I think, you know, wanting to confirm the diagnosis as far, does it restrict on MR imaging?
Well, we can, yeah. First, we were asked what to do at this point of the history. What would you do?
Yeah, I must admit, I you know, given
the baby is not doing well, it's intubated, it's unconscious. We have to find.
So I must admit, I think you have little alternative but to proceed with surgery, and I think accepting the high risks of it, I probably would be looking at doing a craniotomy to start to debulk it. But a part of my strategy would be to get a very early intraoperative smear, because I think that would then really dictate how aggressive I was during the surgery. I guess the other thing is I'd want to make sure is so that one's got some reasonable vascular imaging here, just to make sure this is, its relationship particularly to the deep venous system. Oh, there you go. Thank you.
This is the angiography.
And so, as you say, a bit like your last case, is it that there does appear to be some vascular filling there? What were there any main feeders that were identified on the entire sequence, Giampiero?
Yes, the main feeders were coming actually from branches from the middle cerebral artery, but these were multiple. You see anastomosis here.
Yes. And I guess, having if one's then we've now been able to demonstrate a vascular supply. I mean, I guess the next question would be whether the interventional radiologists could then do anything to try and reduce vascularity.
Yes, that's exactly what we asked him. So again, this is another AGF, some sequences of the AGF. And we asked, can you do something for us?
Yeah.
Because the neonate is always a problem with these large lesions, and one of the problems is really the blood loss that may end in the death of the child.
Of course.
So, yeah. And this is again embolization of part of the malformation with the glue. But he said, pay attention because actually it can be, as we know, a problem, embolize this. But we said yes, but if you can, and so he did. And the problem here was actually what you see. The patient, this is the glue inside, but the patient had a secondary hemorrhage from venous embolism. So this is another large problem that you can have with this kind of patients. So he had venous embolism and secondary arterial hypertension and secondary hemorrhage, which was even worse than the first lesion, because now you see there's a large compression, and so what we decided, the first step, immediately decompressive craniotomy in order to give space to this patient, sure that he could not be probably recovering, but not sure 100%. You have not to be sure that a neonate with bilateral mydriasis will not recover, so you have to try, and that's what we tried, the compressive craniotomy in this child. After this decompressive craniotomy, this was the situation. After a few days, the baby recovered in consciousness. He had a clear right hemiparesis, and this is again the residual of the hematoma, residual of the lesion, and but he's recovering consciousness, no more mydriasis. So what to do now? Going ahead.
Did you take tissue at that operation? Apart from doing the decompression, did you send anything for from the lesion?
Well, actually, it was almost impossible because brain was coming out like like hell for all the surgery. So we were just able to give space, and what we had in the field was brain. We were even not able to go around inside to take some samples. So it was really a kind of salvage surgery at this time of the history. Well, the problem in these children is that once you have tried, and the child, the neonate is showing some tendency to recover, I think you have to try and go ahead and do something more. So we waited a little bit to be sure that the child was recovering, and then this is the 1 month MRI, when the child even recovered some contact, good contact with the parents, he had the right hemiparesis, but it was expected at least that he had the right hemiparesis, and this is the MRI of 1 month. So with this MRI, then we underwent to remove all this, what remained of the vascular malformation, and what actually ended to be almost an hemispherectomy. But you know that even in the past and nowadays, for neonatal epilepsy, in some cases, hemispherectomy or hemispherotomy can be a choice with the possibility of good recovery and condition. So we consider the surgery this child with a similar principle to remove all the malachic tissue and residual of the hematoma and malformation. This is the histology report, hemorrhagic diffuse congenital vascular dysplasia. So again, it's supposed to be possible to be malignant tumor in neonates. You don't have to trust too much on the hemorrhagic lesions, especially in neonates. We have the not infrequent possibility that it can be a non-malignant lesion, and this was our second experience with a similar kind of presentation in different locations, which confirms we have not to trust the child is going to be destined to die because of malignant tumor. And actually the child recovered quite well. This is a third case, but nowadays he's working with sustain. Is now 5 years, so starting to go to maternal school. Yes, clearly need of being assisted by teachers, but is for the rest, I would say, in a reasonable living condition.
Beautiful case, Jean-Pierre. I mean, they're very instructive. I guess one of the lessons from both these cases is the importance of having neurosurgical input into prenatal counseling in some of these cases. I think sometimes, and I see this a lot in spinal dysraphism, that sometimes the prognosis delivered is very disproportionate to the possible underlying pathology.
Yes, I think this is really one of the first things important that I wanted to say. So having the consultation in a center where there is a good knowledge of the possibilities of congenital pathologies is a primary need when you have a fatal diagnosis, and I advise all to send for a second opinion to a center where there is knowledge of possibilities, alternatives to very negative possibilities, which are generally, it has happened to us many times, primarily be considered not compatible even with life. Okay, so thank you, Professor Signa, and thank you, Massimiliano, again for having me today.
Just I want to comment. Sometimes intraventricular congenital teratoma can behave or present like this. So this would kept diagnosis. Sometimes intraventricular congenital teratoma sometimes present like this. So we operated 2 patients like this. And they were nice after surgery.
I think you're muted, Giampiero.
So I understand that you want to ask the possibility of having a congenital teratoma.
Yeah. Intraventricular, yeah. So
yeah, it is a possibility. This one, generally, we are used to this kind of tumor with a more heterogeneous kind of signal. Compared with what we saw in these two cases, especially the second case, which was with intraventricular more than the MRI, but also in the MRI, in the primary MRI, it was a quite homogeneous hemorrhagic lesion, the one of the patients which I presented. In the teratomas and mixed teratomas, especially that we see also in nets, the signal is exchanging with a lot of calcifications also and more cystic components. This is what we so probably will not be. The hypothesis, original hypothesis, could be of a malignant tumor. We just a little bit were less convinced after the angiography, the primary angiography that I showed, because generally the teratoid rhabdoid has not this kind of arteriovenous, large arteriovenous fistula. It's just a diffuse blood inside from the deepest vascular supports of the brain.
Thank you, Professor Giamparo.
You're welcome.
So coming to the next speaker, Professor Duccio Boscarini, he is probably stuck up with some surgery. So his fellow, Mark Prod, he's an orthopedic surgeon, and he's doing his fellowship in spine surgery. He would be giving the presentation on his behalf. And the topic of the presentation is application of robotic Mesorex stealth addition in a challenging iliac screw positioning procedure where high-tech beats conventional procedure. Over to you, Mark.
Yes.
Please, could you share your screen?
Yes, sorry. Dear colleagues, so I'm Mark Prodom, and I will speak with you about a challenging case of iliac screw procedure. We have just disclosure about Dr. Boscarini. He's a consultant for Medtronic, but no funding and no other disclosure was for this case. We will discuss about the description of the case, the planning of the iliac screws, and the surgical procedure steps and postoperative results. So the patient was a 72 years old female with some comorbidities like arterial hypertony, obesity, and diabetes. She had the previous surgery in 2018, double TELIF, L4, L5, and L5S1, and 1 year after, bilateral sacroiliac fusion with the Rialto material. She complained with chronic low back pain with difficulty for deambulation, but there was no specific complication about the scars or neurological deficits. And she mentioned painful right sacroiliac region. So we made a CT scan of the lumbar spine, and so right S1 screw loosening. And we completed this exam with a bone scan, and there is some activity around the screws, and so we have the reflection about the case about the loosening of the S1 screws. Probably it was the reflect of an instability leading to low back pain, And we planned surgery for an extension of the stabilization to the lumbar, to the iliac region, and to replace the S1 screws. And but there was a problem with the presence of the Rialto screws for sacroiliac fusion performed in 2019. We had a robotic solution to adequate plan the screw trajectory considering previous screws in the sacroiliac joint. And this is the planning. It's a special software from Medtronic, and we planned the screw direction on the space, and we
Dr.
can see
Prudhomme?
after.
I'm sorry, we don't see the slides progressing. You're still on the first slide. This is Francesco Lieto.
Oh, it's a problem.
You see it now. Thank you.
And here, it's okay? Or
yeah, we see them now.
Did you see the previous ones?
No, not really.
Maybe we can scroll through the previous then.
Yeah, thank you.
Let's need to start again.
Yeah, but the patient was still the same patients with the previous surgery on the lumbar spine and the sacroiliac fusion bilateral procedure 1 year after. She had what was the same. We performed the CT scan of the lumbar spine and saw right S1 screw loosening. And the bone scan showed activities around the screws. So we decided to extend the stabilization to the iliac region and to replace the S1 screws. Considering the Rialto screws in the sacroiliac region, we planned with the Mazor X Steph Edition software for adequate trajectory. So the software is like this. We performed a preoperative low dose CT scan, and we put the screws on the trajectory, can modify the direction, all the things in all planes of the space. So this is the previous Rialto screws in the sacroiliac joint, and we can adequately position the trajectory of the screws. And to control the direction, it's a frontal view, Rialto, and the iliac screw, and the S1 upper. And so it was my first personal experience with the robotic planning. It was a lot of time, 45 minutes for screw planning, but it was in the office the previous day before the surgery. And the procedure was as follows. So we positioned the patient supine as a regular procedure, and we can anchor the robotic device to the table like this. And after that, we can make the draping of the patient and the robot. And then we put a patient frame on the posterior iliac spine. And the working space scanning is the robotic arm can scan this region with the volume of the region. So we put this tissue on the patient and all the device to have an anti-collision scanning. And then we can make the approach of the patient. And we use the radiofluoroscopy to perform the registration. And there is a special device to have some balls inside to detect and to have the space registration with, in order to perform a good matching with the CT scan. So the CT scan with the screw planning and the fluoroscopic acquisition, it's anterior, posterior, and oblique views, and the matching between the two acquisitions can be performed with bony landmarking. And so the planned trajectory is like activating the movement of the arm of the robot, and the robots can give us the adequate trajectory of the instruments in order to perform all the path preparation of the screw insertion. And the plus one of this strategy is to have navigation, like regular navigation station in Medtronic company. And we can do all the things with the with the drill and all the things to tap and all the things like to prepare the screw insertion. And we put the screw inside the iliac region under navigation. And the operative data was like 2 hours. It's long surgery for just two screws, but it was the first experience. And it was not so long because the 45 minutes of the screw planning was the day before, so not with the patient under general anesthesia. Robotic registration, so with the fluoroscopy, was like 16 minutes. It was not so long, and screw insertion was only 6 minutes with the movement of the arm of the robotics device. Changing of the side, it was 3 minutes per screw. It was not so long, and blood loss was 300 cubic centimeters. So postoperatively, we saw the patient has no pain at all after a few days. She was very reassured because of the chronic low back pain. She had improvement in deambulation, all the things in quality of life, no neurological deficits. But she presented after 8 days at seroma. We wanted to be like cautious with the patient, so we performed one revision with all samples for bacteriological analysis, and it was like totally negative after 14 days, all the samples, so it was no infection, and after that she recovered totally normally. We didn't do some X-rays, so I put the screw use to show the instrumentation. So we changed the S1 screws and put the iliac screws in the previous area and extend the instrumentation. And what is very interesting, it's the screws, the iliac screws trajectory was exactly the same than plans of the planning previously performed. And so we were like very satisfactory results. And I performed the radiation exposure calculation with all the imaging she received. So the low dose CT scan, like 10 millisieverts, and the fluoro registration for imaging matching was 0.25 millisieverts, and the postoperative CT scan was a little bit less than the preoperative, and at the end, the effective dose was 20 millisieverts. So we save time during the surgical procedure with the screws planning, not during the surgery, but performed before, the day before, and surgical planning helps to anticipate the perfect trajectory with the 2 screws of the Rialto in the sacroiliac region. And the stability of the robotic arm helps us to have a very stable screw insertion without toggle. And the postoperative was totally accurate. So thank you for your attention.
Thank you, Mark, for the presentation.
Mm-hmm.
Can you throw some light on what was your experience with O-arm compared to robotic screw insertion in the iliac?
With the arm, we don't do so much. Maybe there was just another case before we had the robotics device. and it was all right, but there was no revision. It was just an extension of the TLF L4, L5, L5, S1 to the iliac region. And it was all right. The OARM is a very satisfactory device for accuracy of the screws and all the things. It's like, very great.
Right. Thank you, Mark. Thank you.
Welcome. Thank you.
So with this, we move to the last presentation of the day. May I request Dr. Dogliato Francesco. He is currently Associate Professor of Neurosurgery at the University of Brescia, Italy. He was trained at Catholic University of Rome and acquired his endoscopic skills under Dr. Frank and Pasquini's guidance at Bologna. During his fellowship, he developed a novel research method, neuronavigation-based, which allows the quantification and comparison of neurosurgical approaches in the anatomy laboratory. Today, he would be talking about the challenge of clival reconstruction in endoscopic skull-based surgery, present scenario, and future perspectives. Over to you, Francisco.
Thank you very much, Dr. Chakrabarty. It's a true honor to be here. So I'm gonna try and share my screen, and it's a true honor to be here. I would like to thank Dr. Visocchi, first of all, and Professor Signa for the invitation. Can you confirm that you are seeing my screen?
Yeah.
Okay. So I have a first disclaimer because I was really fascinated by the title of this webinar. I found it really appealing. But to be honest with you, I even went on the internet and had to look up the definition of miracle. And so my first disclaimer is I'm fairly sure I'm not going to speak to you of a miracle today. But I also found this quote, which I believe is pertinent. And it says, miracles happen to those who believe in them. So what I thought I would do today is I would like to share with you a vision, which I'm very fond of. And I will show you why I believe this vision is important and why we've been working on it for the last few years here at the University of Brescia. So obviously I'm gonna switch gears and I'm gonna speak of endoscopic skull-based surgery. And in particular, I'm gonna speak to you of transclival surgery. And I will start pointing out why I believe this is important. I will then provide you with a brief historical overview, just to show that nothing is really novel. And then I would like to point out the current limitation of this surgery and briefly present to you a potential solution, which is not here yet, but I believe, and again, I believe, might be a solution in the future. So, as we all know, endoscopic skull-based surgery has greatly evolved, and here I would like to remember that unfortunately Dr. Frank just recently passed away. He was one of my mentors and a great pioneer in the field, as you know, for cavernous sinus surgery. But this is not what I'm going to deal with today. I will be speaking to you of transclival surgery, which, as you know, exploits the transnasal corridor to provide you with a symmetric and wide view of the posterior fossa and in particular of the anterior brainstem. So why is it so relevant? I thought I would give you this screenshot of the neuronavigation with a software that we developed in Toronto that allows the quantification of the surgical volume that describes each surgical approach. My residents here performed all the transnasal corridors, transclival, and each color corresponds to one approach. And what is striking, I believe, is that if you take this image and you compare it to what we usually use, and that is lateral approaches to the clivus, you will see that the surgical volume, our working volume with endoscopic transnasal approaches is significantly larger than any other volume that is provided by any other lateral approach. And this also holds true if you look at exposure. So here you see that we studied different approaches, and the mid-clivus is pretty much exposed satisfactorily by endoscopic and marked surgical approaches. But if you then look at the extremes, you do see that the upper clivus and the lower clivus are much better exposed by endoscopic transnasal approaches rather than lateral approaches, which, as we all know, if we want to deal with the clivus, means that we're working in between the cranial nerves. So if you want more details, these results have been published actually in 2 papers. The last one is really, I believe, quite complete, and you can look up more details. But my other message today is the transclival approach novel? Well, we looked at the literature systematically, and these are the reported patients that have been treated in the last 60 years, I apologize, 60 years with a transclival approach. As you see, there are some reports even in the 60s and even for vascular pathology where a transcervical transclival approach would be used. Then, as we all know, in the 80s, the transoral approach was quite popularized. And as you see more recently, with the introduction of endoscopy, the transnasal endoscopic approach has been described significantly more than in the past. If you look at the different pathologies, pretty much malformative, but also vascular and intradural, mainly pathology has been treated, and more so recently. But if you then look at the centers that have been reporting, these remain relatively few, even in recent years. So we're always at around 10 different centers reporting on transclival intradural surgery. And what is striking, and this is a very busy diagram, is that if you start looking at how people have reconstructed the clivus throughout the last decades, you will find very different materials and also significantly different techniques. And why is that? Well, the reason is that this approach has a major Achilles heel, and that is the reconstruction of the clivus once the approach has been performed. And so skull-based reconstruction is certainly challenging in the area, especially when large clival defects are necessary because of the complex geometry, because of the wide cisterns that are just behind the clivus, and because once you have a large defect on the lateral borders of your approach, you will have pretty much all the cranial nerves, which obviously should not be injured. And so right now, as skull-based surgeons, we do know that the gasket seal technique is ideally what we would like to use, but because of the complex geometry and because of the proximity with the cranial nerves, once a wide transclival window has been created, the gasket seal technique is no longer feasible. On the other hand, as neurosurgeons, and I was really happy to hear about 3D printing already for the spine, As neurosurgeons, we are now exploiting the innovations in materials, design, and fabrication that the engineering field has seen in the last 3 decades. And as skull-based surgeons, we do use 3D printing in other areas. And this is a large sphenoorbital meningioma, which we just operated 10 days ago, in which the reconstruction of the bone after the large defect that was created with removal, well, the reconstruction was performed with a custom-made prosthesis. And I have to be honest, this was our first case, but I'm really satisfied with the result. Well, then as we are becoming more familiar with 3D printing, the obvious question was, can we apply this to the clivus? And so our vision was to do this, and our method was to go back to the lab and set up a preclinical evaluation of reconstruction of the skull base using 3D printing. I'm not gonna go into details. So this is just a busy slide to show to you that we performed different clivectomies. We're obviously measuring them in different, in 5 specimens. We tried different solutions. And as I could show you here, we then concentrated ourselves on the prosthesis enhanced by these wings through which we could position screws. But really, the most important part of the study, I believe, was to perfection a preclinical model for assessment of the mechanical rigidity of a skull base reconstruct. So really briefly, in our specimen, we would position a subdural catheter, and after skull base reconstruction, we would then be able to measure the what we call the CSF leak pressure point. So the pressure at which a leak through the construct would be evident. And this is what we would do in the lab. The clivectomy has already been performed. Fascia temporalis has been positioned over the defect, and we have the scaffold in place. Screws are positioned. Obviously, this is done under navigation. And here I'm going to show you not the perfect case. As you see, one of the wings broke. And this is the evidence of the leak, which at this point was at 68 centimeters of water. Obviously, all specimens underwent a CT scan to check the position of the scaffold, which was satisfactory in this case. But most importantly, this is what I believe I should stress. We were able in 3 specimens to perform the CSF leak pressure test. And as you see, the best values were evident when we were using the scaffold with wings and screws. And actually in the one where we could use both screws, we did reach pressures which I believe would be clinically significant. So just to conclude, I believe we were able to prove that 3D printing can be extremely useful even in skull base reconstruction of the clivus, providing patient-specific scaffolds. Obviously, further research, and we have a few projects ongoing, is necessary to develop the ideal material, which should not only be osteoinductive, but should also have antibiotic and antimycotic properties But again, the aim of this presentation was just to provide you with a vision, and I would be happy to discuss more details. And with this, I would like to acknowledge at least the leaders of this group, which is obviously larger, as many young neurosurgeons and engineers are working on it. So thank you very much.
Thank you, Francisco. Very interesting presentation. I have a question. Suppose many a times we need to take out part of the clivus, and the geometry of the part of the clivus which was demolished, if we want to reconstruct that with one of the 3D printing systems which you had, I mean, will it not take some time for the material to be printed when you're doing intraoperative demolition
Yes.
of part of the clivus?
Yes, so this is an excellent question, because if we want to move this to the clinical scenario, we obviously have to take into account that the ideal reconstruction should be performed at the first surgery. So I didn't go into detail, but we were able to prove that we can draw the defect of the clivus, which we think we will do. We can check intraoperatively, and I mean during the simulation of surgery in the lab, we can check intraoperatively that we are doing as planned. And what happens is, once we have proven that this prediction is feasible, and that was proven, then I can conceive that a patient would come to me, it would be planned for surgery, we would predict the clival defect, and ideally we would take a month or so to create the prosthesis, because in our vision, the prosthesis would not only be made in PLA, but it would be a porotic material which would have stem cells taken from the fat tissue of the patient and re-engineered into osteoblasts. Furthermore, the material should be covered with gelatin, which ideally would have antibiotics and antimycotics personalized on the patient flora. But this is just beginning, as we have preclinical data on promising porotic materials, and we're looking at bone regeneration in the animal model together with the University of Toronto. But obviously this will need, I believe, a few years to come into clinical practice. But if this becomes possible, I believe transclival surgery might change or might give us an extra tool to deal with challenging lesions of the posterior fossa.
Thank you. Thank you.
May I make a comment and a question, please? First of all, I want to congratulate Dr. Doglieto for his very innovative and brilliant presentation. As far as I understand, it is possible to screw the condyle by the nose. Is it correct? In other words, the screws, as far as I understand, is put on the most hard and thick part of the anterior, surrounding the anterior the clivus, the condyles. Is it correct?
Yes, so this is another excellent question, as we are looking into safe entry zones of the bone around the clivus, and these obviously change according to the type of clivectomy. But yes, it is correct. Once the widest clivectomy is performed, and that is as lateral as the hypoglossal canal, the condyle will be the targets for the screw. In my presentation, we were lucky enough in the 5 specimens to even have an anatomical variation in which C0 and C1 were fused. Obviously, in such a case, C1 would be easily used as it would provide a more medial target. But what I found that was striking is that it is feasible to go as lateral as the condyle from a transnasal approach. Sometimes this should be coupled with a transoral route, because as Professor Visocchi knows, that will provide a much more lateral angle. And so the screw might be also positioned using the mouth to have a more lateral angle.
And if we check the scalp-based model and according to your anatomical experience, I think that the best way to purchase an occipital condyle, for instance, the left occipital condyle, is to gain access by the right nostrils, because they are 15-degree converging, and the only risk if you do this operation by using a neuronavigation, intraoperative neuronavigation, is to impinge the hypoglossus nerve. But you have many ways to avoid it. Neurophysiological monitoring, the same neuronavigation with intraoperative OARM or CAT scan can be useful for that. And I think that very genial intuition to overcome the problem related to the clivus reconstruction, which is a detachment of the prosthesis from the clivus due to the pulsatility of the CSF. So congratulations for this very innovative communication and intuition.
Well, thank you again for having me here. I thought it would be important, as this is the Neuro Rehab and Reconstruction Committee, to share this idea with you.
And, I also want to congratulate you for a very nice and beautiful presentation. And we do a lot of surgery with the 3D technique, but this is amazing. Your work is amazing. Congratulations.
Thank you.
So now we have to conclude this meeting. No, Virendra.
Yeah. So again, good evening to everyone. And my special thanks goes to all the speakers and attendees on the webinar. I'm thankful to Dr. Visocchi for planning and coordinating this webinar. And he has chosen all the speakers very nicely. And it was definitely share of this knowledge will help our patients. And please stay safe, and my best wishes in advance for Christmas and New Year, because thank you everyone. Thank you.
Thank you. And keep in touch. Keep
in
touch.
Sure, yeah. And I think I just want to give idea that we can have a webinar on 3D only. So I can share my experience. We are doing all tumors, CV junction, cranioplasty, the 3D technique only. So we can share with the. So we will keep in touch, right? Okay.
Okay. Bye bye.
Bye bye. Bye bye.